Jacob sir has also joined.
First of all, I'd like to welcome you all for this 29th session of Peculiar Case Series in Renal Transplant. We are meeting after 2 months. We gave a break last month because of ISOT meeting. And as usual, we have two exciting case presentation, which will be adorned, which will be chaired by two panelists, eminent panelists. And following both the case presentation, we have discussions and a wrap-up message. Let me take a privilege to invite Dr. Sheelata, one of our panelists. She has come twice. Second time she is coming as a panelist, and people don't need much introduction about her because she's a very good teacher. Actually, she's a very good teacher. Is sound in his knowledge, and sound in basics in nephrology as well as transplant. I had an opportunity to have an observer during my DM days in a center. And one thing I came to my mind was she was a great teacher and she had many followers. And she had very many publications, very many papers, and she had presented at a lot of conferences. His knowledge in nephrology is somewhat crisp and it should be adored of. And joining her is Dr. Ilangovan Veerappan. He's a product of CMC Vellore. Now he's a chief nephrologist at KG Hospital in Coimbatore. And he's a product of CMC Vellore, and he's a good friend of mine, and he's very good in transplant, and he had a very complex transplant to his credit, and he's also a good teacher, and he has a reviewer of many journals, and is somewhat a person to have a discussion when you have a problem in transplant, and we are happy to have him here. And we hope that his inputs will put a lot of insights into the cases being presented. And two presentations, one by Dr. Satish Balansar team. And Satish share what to tell about him. And he's an active member of our Peculiar Case Series group. Whenever a doubt comes, whenever a messages regarding transplant issues comes, he chip in with a lot of ideas, which many times will be accepted by the members of the peer members. And he is one of the top-rated peer reviewer of nephrology journals in India and abroad. And sir is always for help when you have trouble in nephrology. He's a great teacher, and his basics are very sound. So he'll be a speaker, and we'll be considering him as one of the unofficial panelists in our session, actually. And joining him to present his cases is Dr. Saravanan. He's a young dynamic nephrologist and from Apollo Hospital, Chennai. And he's also a product of CMC Vellore. And he's a gutsy nephrologist. He used to do high-risk transplants. And why I'm saying that, once after his case presentation, we'll be knowing that how brave and how eminent he is in tackling transplants. He's a good knowledge about transplant. And hope he's a speaker of he's an invited speaker in many conferences. I recently heard his talk at Southern Chapter Coimbatore regarding renal donors. So very happy to have you as a speaker. And once again, welcome the delegates who have been even if their busy schedule has joined this meeting. And we hope that this 1 hour will provide us a good thought to our nephrology ideas, and happy learning for next 1 hour. Without wasting much of the time, I invite Dr. Satish and team, Dr. Meenu, going to present the case. I invite Dr. Meenu to start her presentation.
Thank you, sir. Sir, is it visible, sir?
Yeah, visible. Go.
Okay. Good evening, all. I am Dr. Meenu, final year resident from Nephrology Department, KIMS Health Trivandrum. We are here to present before you two peculiar cases. We would like to call it as dark clouds and a thunderstorm. It's an analysis of a rejected graft.
Meenu, your slides are not moving.
Yes, sir. Just stuck actually. Yeah.
Yeah, moving.
This is the first case. This is a 35-year-old gentleman, IT professional. His blood group is O negative. He first visited our hospital with advanced kidney disease on January 2023. He had history of severe hypertension in 2019, but lost follow-up. Later in December 2022, he was admitted with pulmonary edema and nearby hospital. His creatinine was 10.75 at that time. Imaging showed bilateral contracted kidneys. So he was initiated on hemodialysis at nearby hospital via right IJV tunnel catheter. No history of blood transfusion. And he basically came to our hospital for transplantation workup. His mother was evaluated as a donor. Her blood group was B positive. So it was basically ABO incompatible transplant. So transplantation workup started on February 2023. Both donor and recipient got clearance from all departments. CDC cross match as well as flow cross match were negative. HLA showed 3/6 match. We didn't do a SAB for him. Anti-B titer by IgG column method was 1 in 122, initial titer. So desensitization protocol was initiated with injection rituximab, 100 milligram IV was given in first week of June, and 7 sessions of plasmapheresis was done. And after the 7th session, his titer reduced to 1 in 60. As per our hospital protocol, we are doing ABO incompatible transplant when the titer is less than 1 in 32. So he was taken up for transplantation at this titer on 5th July 2023. An induction was given with injection graflone 200 milligram IV, injection methylprednisolone 1 gram IV, and tacrolimus 4 milligram. And transplantation was smooth. Anastomosis was very smooth and with warm ischemia time 4 minutes and cold ischemia time 65 minutes. And on clamp reliefs, kidney became pink and turgid, but there was no brisk diuresis. Only few drops of urine came. Within a few minutes, kidney became flaccid and dusky with no urine output. Then intra-Doppler was done, which showed very high resistance of intrarenal flow and hyperacute rejection was diagnosed. So it was informed to relatives and an on-table graft nephrectomy was done. And patient was shifted back to transplant ICU. This was the specimen, nephrectomy specimen. And he was put back on dialysis. Then the worst thing happened. Relatives were not accepting the hyperacute rejection. The chaos and dispute began. They were started blaming us for negligence. And then the pathologist report came. They confirmed hyperacute rejection after examining the nephrectomy specimen. With available reports and the evidences, we had to convince them the facts that hyperacute rejection is not an uncommon experience and ABO incompatible transplantation even after desensitization. And its incidence ranges from 5 to 10% in various centers. And keeping a hyperacutely rejected graft in situ, it may lead to DIC in the patient. So we have non-functional graft has to be removed. After convincing all these things, he got discharged on maintenance hemodialysis after 10 days. But after discharge, he filed a criminal negligence case against us. And these were the histological slides. These are the low power and high power view. It shows extensive ischemic necrosis and dense neutrophilic infiltration were suggestive of hyperacute rejection. This is the C4D staining, shows more than 50% of capillaries showing C4D staining, that C4D score 3. So this is the second case. It is almost 1 week later, the first case. This is a 16-year-old girl. She was a 10th standard student. Her blood group was O positive. First child of non-consanguineous marriage with normal antenatal history, birth weight of 3.8 kg. She was under follow from Medical College Trivandrum since 2021. After which she was she was admitted with fever and vomiting in August 2021 and was diagnosed as pyelonephritis and was treated as with IV antibiotics. His initial USG KOB shows swollen hypoechoic kidneys. And following that episode, she had recurrent episodes of UTI. In August 2022, they noticed persisting proteinuria and microhematuria with deranged renal function with a serum creatinine of 1.9. So further workup were done. ANA was positive, 1 plus positive, anti-dsDNA was negative, C3 was normal. Renal biopsy was done, which showed 14 glomeruli, 9 obsolescence, with mild mesangial hypercellularity, and IF almost full house with IgA negative CBC counts were hemoglobin, total count, platelet, ESR were normal. Urine routine showed 2 plus proteinuria with 4 RBCs per hyperfield. And on follow-up, there was rapid decline in the renal function and creatinine reached 4 in 2 months. So she was initiated on pulse steroid following oral steroid, and she was continuing omnacotil 20 milligram once daily. And there was a history of blood transfusion also in December 2022 because of anemia with a hemoglobin of 7. And with all this history, she came to our hospital and her parents opted for a preemptive renal transplantation actually. But during follow-up, there was worsening renal function and her creatinine rose to 7 milligram in the next 2 months. And her mother was evaluated as a prospective donor. Her blood group was A positive. CD6 and flow cross match were negative. HLA showed 3/6 match. For her also, we didn't do a SAP. And because of worsening renal function, fluid overload, and refractory hypertension, she was initiated on hemodialysis via right IJV temporary hemodialysis catheter on May 2023. And meanwhile, clearance obtained from all departments for both donor and recipient. And her anti-A titer was 1 in 64. So desensitization protocol was initiated on 1st July 2023 with rituximab 100 milligram was given. And 3 days later, her anti-H titer was checked. It was 1 in 32. And she was initiated on plasmapheresis along with tacrolimus 1 milligram twice daily and MMF mycophenolate mofetil 500 milligram twice daily was also started. Total 5 plasmapheresis sessions were done with serial monitoring of anti-A titer. And last session was on 12th July. And post-plex titer was 1 in 4. And renal transplantation was done 2 days later, that is on 14/7/2023. An induction was given with basiliximab 20 milligram, methylprednisolone 1 gram, and tacrolimus 4 milligram. Anastomosis were smooth with a warm ischemia time of 4.5 minutes and cold ischemia time of 68 minutes. Following clamp release, allograft kidney became pink and turgid immediately, and there was steady diuresis. But and after the patient was shifted to transplant ICU, and in the immediate post-op period, there was reduced urine output, and Doppler was done. It showed no flow beyond main renal artery. So the same was discussed with the urologist and bystanders, and re-exploration was done on the same day itself. And intraoperatively, bluish discoloration of the graft was noted, and intra-op Doppler was done, showed high resistance waveform of the intrarenal vessels with absent diastolic flow. So again, rejection, acute rejection was diagnosed, and intra-op reperfusion of kidney was done, and graft color changed to pink, and on-table plasmapheresis was also started simultaneously. And we did an on-table renal biopsy, but there was bleeding from the biopsy site and severe hematuria. So we had to transfuse 3 units of LDRBC, and plasmapheresis had to be stopped due to severe bleeding and coagulopathy. After achieving hemostasis, the patient was shifted to transplant ICU, and then we continued IV steroids and MMF. But the graft function didn't improve in the next 48 hours. She was initiated on hemodialysis. And meanwhile, the biopsy report came. We showed 17 glomeruli with capillaries showing fibrin thrombi, mesangiolisis, neutrophilic infiltration, tubular damage with loss of brush border, occasional neutrophils in the peritubular capillaries, and arteriole showed fibrinoid changes with neutrophils. These are the histopathology slides. And we discussed the same, the biopsy finding with the bystander. Both urologists and nephrologists together sat with the bystander and discussed the status of the graft, and also discussed the need for graft nephrectomy. After obtaining consent from both relatives and from the patient, graft nephrectomy was done 2 days later, that is on 17/7/2023. Then post-operatively, maintenance hemodialysis continued via right jugular tunnel catheter and immunosuppressants reduced. She was continuing Bisolone 5 milligram once daily. And initially, father was accused us of negligence, but mother, who was the donor, she was there in the transplant ICU throughout. She was strong enough. And so the matters didn't go out of our hands this time. And currently, she is under our follow-up itself, and she is undergoing twice weekly hemodialysis. A few words about ABO and compactability. ABO incompatibility, it was an important barrier in kidney transplantation due to its complication, that is hyperacute rejection. And use of plasmapheresis was a watershed moment in the history of ABO incompatible transplantation, and first successful series of ABO incompatible transplant with the use of plasmapheresis and splenectomy was by Alexandre et al. From Belgium. And then come the use of rituximab in late 2000s, which replaced splenectomy. And significant improvement has occurred in outcomes of ABO incompatible transplantation with various preconditioning protocols. But still, the incidence of hyperacute rejection is 5 to 10% from various centers. In our center, almost 25 ABO incompatible transplants has been performed over the last 15 years. And this is our first experience with hyperacute rejection. Why these two cases have been presented? Because to convince the facts that ABO incompatible transplantation can sometimes lead to hyperacute rejection, and the occurrence of this is unpredictable and doesn't depend on the pre-op titer. And the medical complications can be handled well upon acting swiftly, but the social as well as economic consequences are unpredictable and should be anticipated. Unnecessary legal issues can drag on, so proper video consent is a must. Actually, I invite Satish sir for further discussions of the case. Sir?
Sir?
Yeah. So, we just want to present this case because of this important problem of hyperacute rejection. So actually, this actually led us to go into why this hyperacute rejection is occurring in transplants. So, and as you know, this is a case of dark cloud where the thunderstorm was the negligence problem that we did not expect actually. Where am I? My Zoom is gone. Yeah, it is. Okay. So our big problem, actually, let me get my slides on. So actually, you can handle the medical problems. I think we are sufficiently good enough to handle all the medical problems. But the other problems are what happens. In fact, even this case has been dragging on. They filed the case in the police station. And then actually initially they asked us to come to the police station, me and the thing. Then we discussed with our advocates and all that. And finally the police came to us. So they had, and I realized one thing, what they were asking is about whether this thing had been told to them or not. Fortunately, we had a detailed discussion and we had video proof that we had already discussed this. And I also said that during the video consent, we had specifically mentioned that there is a chance that you may have to pay, whether there is a severe rejection, you might remove the kidney and throw it away. So that was what saved us, I think. So the police were also convinced, but I don't think these people are still convinced. They may go ahead with the further action also. This is not coming full screen for some reason.
So making as a slideshow, sir?
Yeah, it's not coming as slideshow.
Yeah.
You see?
Yeah.
Now it's come, no?
Yeah.
Okay, so let's just see why this thing should occur at all in the first place. So first of all, the question is, why do we have different blood groups? There's no reason, no? Why don't all of us have same blood group? So there's believed that there is some evolutionary significance. What it is, nobody says. And some blood groups may have protected against some disease in the past, and that may be why we are having it. So different blood groups are also seen in other primates. They're also seen in dogs, cats, and other things. So many of the vertebrate species, but not all vertebrate species, some of the fish and all that, they don't have blood groups. So, but there are, most of the mammal category, they all have blood groups. So there must be some significance. Otherwise, we should not have these blood groups. Why? What it is, we don't know. And the blood groups are different for cats, dogs, and all that, and for human beings. So Karl Landsteiner was the first person to describe blood groups. He received the Nobel Prize in 1930 for this. But 100 years later, we don't know how the antibodies form to these blood groups. That is also a mystery. So first, why we have blood groups, different blood groups, also a mystery. Why the antibodies form against them is also a mystery. So the common belief till now, and there were some studies which showed that this is actually derived from exposure to microbial antigens in infancy. And these microbial antigens cross-react with blood group antigens, and therefore you get anti-blood group antibodies. seems like a reasonable solution. But just last month, one study was published in Transplantation Journal, in which they have carefully studied mice, and they have shown that without microbes, you can develop antibodies. So in an absolutely microbial environment, the mice have developed antibodies against blood groups. So this theory is also gone. Now we have to formulate new theories. That's going to take some time. So let's see a little bit about B cell phenotypes, because this is going to be important for our discussion. B cells are of two types, B1 cells and B2 cells. So these B1 cells are actually derived from the fetal liver. So they don't come through the bone marrow at all. And they are in the fetus, they're actually very important. More than 50% of cells are B1 cells. But in the adult, these cells are present only in the pleural and peritoneal cavities to some extent, but not in the rest of the body. And this is actually B1 cells are part of the innate immunity. They do not have this VDJ rearrangement, and they do not have somatic hypermutations. And so they do not participate in the acquired immunity. Whereas B2 cells are bone marrow derived. And once they're bone marrow derived, due to influence of certain materials in the lymph node, they become either the follicular B cells or the marginal zone B cells. The marginal zone B cells are another interesting B cells which are present in the spleen. They are present just outside the white pulp, and they patrol the area near the white pulp. And anything that enters into the white pulp has to be screened by the marginal zone B cells. Only they will allow things inside. And these cells are very important because they are developed also, they're not very well developed in infancy. And so the marginal zone B cells are what produces antibodies against polysaccharide capsules and the organ. That's why infants are very prone to diseases with capsulated organisms. So marginal zone B cells, they are also important. But for the purpose of discussion, what we are important is B1 cells. So the B1 cells, as I said, they belong to the innate immune system. Then they produce natural antibodies. Why they're called natural antibodies? Because they don't require antigen. At least there is no exposure to antigen from outside for them to produce. So maybe some internal antigens are there. And they are the main source of ABO antibodies. So these cells are always CD5 positive, but now recently they found that CD5 negative cells are also can be called B1 cells, and they are now called as B1B cells. So there are B1A cells, which are CD5 positive, and B1B cells are CD5 negative. And these cells usually produce low affinity IgM antibodies. So initially it was again thought that this produce only IgM antibodies. But now we see that some of them produce class switch IgG antibodies. Now these IgG antibodies produced by B1 are always IgG2, not IgG1, 3, or 4. So that's a very important thing, because IgG2 does not fix complement. So how do these ABO antigens stimulate the immune system? So now because B1 cells will connect everything together. So the ABO antigens are polysaccharide antigens. The MHC does not recognize polysaccharide antigens. So therefore, these antigens cannot attract T cells because they are not taken up by the APCs. They are not presented to T cells. So these antigens cannot attract T cells. So what happens is these polysaccharide antigens, they will stimulate the complement pathway. The alternate pathway is stimulated by all these vague antigens. And then they produce C3 activation and C3D formation. So you can see you're taught C3A, C3B. But this C3D is important because the C3D will then stimulates the B cell to bind the antigen with C3D. So the antigen which has bound to C3D will then bind to B cell. That's what I meant. So what happens is when the antigen binds with C3D, it becomes highly antibody stimulating and highly presentable to the B cell. So if the antigen can actually stimulate B cell on its own, but it requires a very high quantity. But when it binds to C3D, 10 to 1,000 times less number of antigen is enough to stimulate the B cells. So you can see that that is what C3D does. It makes this antigen very antigenic. So these B1 cells will then produce antibody, mostly the IgM. And you know that these B1 cells are not stimulated by T cells, so they do not undergo a T cell mediated affinity maturation, all those things. They don't produce, and they don't produce long-lived plasma cells. Unfortunately, the B cells are very long-lived and self-renewing, so they can behave like memory cells, even though they are not actually memory cells. So where do these antibodies come from and when do they form? So that brings us to another player called Laurie West from Edmonton. She was actually a pediatric nephrologist who undertook ABO-incompatible heart transplants in infants. So she found that children with congenital heart disease, they are dying because they're not receiving hearts in time. So as a desperate measure for congenital heart disease, they did a series of 10 children with ABO-incompatible transplants. And they found there is no preparation. There's no pre-medication, nothing. They were just given transplant just like any other children who are doing ABO-compatible transplants. And they found that ABO antibodies did not form in neonates and young infants, and they safely accepted incompatible solid organs. And not only that, the amount of titer of anti-A, anti-B antibodies in these children were much less than compared to control children. So they have a specific immunity against that particular antigen which they were exposed to in infancy. So that is the important thing. So what the important fact here is that infants can be given incompatible transplant without any problem. So what all we have learned so far is that ABO blood groups are determined by inherited parental haplotypes. ABO antibodies are not produced in infants, probably in later in childhood only they formed. And the antibodies are produced by B cells of B1 lineage by interaction with C3d coated antigens. And these antibodies are usually IgM, sometimes IgG. And they are believed to be found by cross-reacting microbial antigens, but as we know, the recent Zone study contradicts this belief. And so we do not know exactly why they are produced. We do not know exactly when they are produced. So basically, our knowledge is just scraping the bottom of the barrel. What about hyperacute rejection? Now, that is also an enigma because it is present in most series of ABO transplants, about 5 to 10%. It does not depend on the antibody titer before transplant. You can have a higher antibody, you can have lower antibody, still they can return. And almost always, this occurs in blood group O recipients only, not in A or B. So that's a very important thing. Why? It's very careful about O recipients. Unfortunately, what happens is that most recipients when you're doing ABO are O group only. So if you see your series, most of them, about 50 to 60% will be O, only the rest of it will be A to B. Why this occurs, we can only speculate. So one of the things is that the stimulation of B1 cells produces IgM antibodies and IgG of IgG2 subtype. O recipients have higher level of antibodies, and some of them may have IgG1 antibodies, which is very strong complement fixing antibody. In fact, there was one study from Korea where they found this hyperacute rejection, and then they investigated, they did a flow cytometry, and they found IgG1 antibodies which are present. So they presume that presence of IgG1 antibodies may be the factor which is leading to a hyperacute rejection. So maybe what happens is that these antigens, that ABO groups in this, are actually stimulating B2 cells and leading to IgG1 response. So perhaps we may characterize the ABO antibody by flow cytometry, and that you can predict ABMR post-transplant. But then unless we do a study, we can't be sure. So to summarize all this is that O group recipients are most likely to develop HAR after ABO transplant, and maybe due to a switch in antibody production from B1 cells to B2 cells, and the production of IgG1 antibodies which are complement fixing. At the present level of understanding, it's impossible to predict who will develop the antibodies, when they will develop, and what is going to happen. The second point is that we should do a SAB in all patients because we don't know in our patients whether this is actually an HLA antibody which is producing. Even though they were negative for this thing, these are all high-risk patients. So probably SAB should be done in all patients who are being planned for ABO incompatible transplant. Anyway, we are spending a lot of money, so a little bit more on SAB should be done. And then, of course, the legal problems, careful counseling. You should always tell them that there is a chance of hyperacute rejection, 5 to 10% chance. And take a video consent so that tomorrow they cannot say that you didn't say that. So that's all I have for you today. So we can have a discussion on this case. Thank you.
Thank you, Satish sir. It's really wonderful basics, actually. And thank you very much for sharing these slides also. And I'm very sorry for the happening, but thanks for bringing in the dark side of a transplant. Many will be putting the rosy picture, and thank you for bringing this also. And a small which I encountered actually is ABO tissue. There is two types of antigens. What I encountered, one is tissue type of ABO antigens, and red blood cells induced blood group ABO. What we are encountering in the rejection is tissue ABO. It has a glycosylation. There is a slight difference in glycosylation. That's why we tend to have a rejection even with your low titer. So blood group titers doesn't anti-A or B titers won't predict your rejection episodes. That's another one thing. What I learned is ABO, there is a 2 or 3 days of, even though on-table rejection can occur, usually it takes 2 to 3 days of honeymoon period actually because of this tissue antigen. Once you get exposed to the cells and they will produce antibodies against it, then you will have a rejections. Most of the rejection in ABO will be around 2 to 3 days after that honeymoon, 5 days actually, 3 to 4 days of them. Sometimes can occur, but many papers, many things I have studied, what I have learned from that. So this is possible that you can have a HLA antibodies and hyperacute rejection because second transplant as having a blood transfusion, and that could be a possible, that could be a HLA mediated one also. So anyway, it's a very good cases and high opener for us to have a video consent. Even I could remember one of my good friend of mine in Trichy had a torrid problem and he had a hyperacute rejection. This time this was not ABO and ABO compatible transplant, and his peace of mind, everything has gone, and to the extent that he stopped doing renal transplant. So such amount of media players, media and politicians have involved, and a lot of trauma. And ironically, that patient was done under a CM scheme. So CM scheme people, a technical committee are involved and government involved in this. And he had a very torrid time. Rightly said, it is one case can pull down the nephrologist conference. And
Yes, yes,
thank you very much for sharing these cases. And this
two
opened
cases
this.
occurred within 1 week of each other.
Yeah, that is a great conference breaker for you and the patient in the waiting list also. Those who are waiting for transplant, they should be their conference will also be detached, sir. Thank you very much, and hope that first case won't trouble you much. Actually, they should. Ideally, that advocate people, what they will do now, they will stimulate the patient, so they will complain against you through the. Actually, one is a lawyer. Through lawyer, they will give the notice, and then will complain to the medical council of India. So they will approach in different way, and this is foolproof, and they cannot do anything much for that actually. So with this, I can open the discussion to the panelists. Srileda, madam, your opinion, please.
Yeah. Thank you, Dr. Satish, for your wonderful presentation. Really an eye-opener for all of us. We do ABN-compatible transplant very liberally. And luckily, we have not come across any hyperacute rejection till date. I should expect it at any time as per Satish's experience. I have not noticed that O group has more chance of hyperacute. That is a new
Actually, I discussed with many of the people who are doing this Tikra group and then with Shyam Bansal and everyone. So all of them have experienced only with O group. Nobody has seen any other group.
We have now crossed around 44 ABO incompatible transplant.
That's good.
And in our experience, it is better than an HLA incompatible. If nothing happened in the first week, they do very well.
Things go smooth, it is very nice.
Till that point, it is nice. Out of that. As you said, the video consulting is a must to prevent all these medical legal issues. That is also. And people are doing ABN compatible at a high titer also, up to 1 in 128 they are doing, isn't it? But without any significant problem. But in our center, we restrict to 32. Up to 32, we do plasma exchange and go ahead.
We have done in 2048, one patient. So we lost 1 year of our life because of that, because he had saw a lot of problems in the post-transplant period, but he did not have any rejections. And hypotension, shock, bleeding, anemia, infection, everything. And 2 weeks we didn't sleep properly.
Satish, for that patient whom you are telling about the 2048, you used column or regular plasmapheresis?
Actually, we used plasmapheresis. We were actually overconfident. So we did, I think, some 18 session of plex for him. Got it down to 1 in 32 and did the transplant. So we did one plex just before surgery also.
Bleeding complications were high because of large number of plex.
Yes, yes. We had to give tons of blood and blood products.
What replacement you are giving, sir, for plasma regularly in your center?
Usually we do albumin for the first few transplant, for the first few plex. And then for the last 2 or 3, we use FFP of the donor group.
Okay. So volume by volume, or how much you will be giving?
Actually, we don't give full volume.
Full volume is not given. If it is 75%. Yeah.
Okay. Thank you.
We do DFPP also now, because if you are having a higher thing, that becomes cost effective.
Yeah.
Because double filtration plasmapheresis, you need to use only much less plasma.
Much less plasma.
Only 20% replacement is needed. So that way it's very effective. The filter costs 50,000 extra, but you can reuse that also. We reuse that 5 times. So we can use 5 DFPP and everything is fine.
Okay. I think Ilangon sir is not there in that. Actually,
I'm around.
Yeah, sir. Your own opinion. Sorry.
I missed the case actually, but I think first compliment to Sir Satish sir. We all know about him. Like, he's really brave. I think in front of patients. And I just want to ask him one question. So how much stress you had when you had the second case?
Actually, second case, I thought, see, we had one problem. Lightning does not strike the same place twice, but sometimes it does. That's what happens. So I never expected second case we will have a hyperacute rejection. And we were particularly careful. We got the titer to 1 in 4 and we did everything what we could. But then, and immediately post-transplant, the kidney functioned well. There's nearly 1 liter urine output. So we are feeling happy. Everything is fine. Then I just went and checked the Doppler and I found this hardly any flow. Only the main renal artery I can see flow. Then I thought maybe this is a vascular problem. So that's why I called the surgeon. Immediately we shifted the patient back and so then I saw the kidney. It was there. And checked the on-table Doppler and that was showing interior flow was there everywhere throughout. But it was all just one line. And then no diastole at all. But this time we thought we won't remove the kidney. We'll reperfuse and keep it back. Because I didn't want on nephrectomy immediately. So
and how convinced were you in doing plasmapheresis, sir? Because I think this kind of situation, plasmapheresis does not really help much.
I thought, see, this was only last minute desperate effort. And we didn't do full plasma because she started bleeding. So we had to stop.
Yes,
we did hardly around 500 ml or 600 ml before we had to stop because she was bleeding from the biopsy site. I think urologist got a little bit overconfident. So he said there is that avascular plane. He'll do biopsy there and they started bleeding like from both sides. We bleed outside and bled inside also. So the hematuria plus bleeding. Well, bleeding outside he fixed with a suture. But inside bleeding, then we held the that renal pelvis together and tamponaded the bleeding. So
one case I also had similar case, like it also happened in the second transplant. We did ABO, and so the learning we had was like same thing. Like we should we used to do the lysate DSA. Like till recently, I never knew that it's waste of money for the patient. Lysate DSA doesn't really help you much. So these days we do PRA, and PRA if is negative, then we don't even think about doing an SAB, but it saves money and time for everybody. So if class 1, class 2 glows up, then we do appropriately whichever glows up. It's class 1 positive, we do class 1, if class 2 positive. And next, so I think
that is our policy also, but I just learned that we have to do SAB for these. These are all high-risk patients. So we should be doing SAB in all of them. That's what I was told. So
and what about non-HLA? Because I think especially for the second transplant, normally we don't do it, but then now and I'm sure like this one we should also evaluate in retrospect. Like I mean, I'm not saying like prospective. Well, I wouldn't have even checked for a non-HLA because the previous one was a late rejection, and late rejection, a significant proportion do have non-HLA also. Only thing is we don't look for it. Look for it diligently, and especially if it's violent, we should strongly consider non-HLA also in addition to AP as well as anti-HLA.
So the second patient, we are planning to do a second transplant, ABO compatible this time. No ABO compatible for her. But so at that time, I'll be doing a SAB, definitely.
What about anti-HLA?
I mean, the other things we can't do it because it's not available generally. They are all doing only as part of research protocol. Commercially, none of the non-HLA is available for testing. So it's a lottery. If it happens, it happens. We can't do anything.
So, Ilangon sir, do you have any experience of doing how specific non-HLA antibodies actually? They are available here, and is there any antigenic specificity as HLAs, and you have a certain amount of antigens coated, and you will be directing against that one, whether it is representative of the patient one?
We are the founding batch for that Dr. Shruti's lab.
Okay.
Shruti's lab. So I've been with the lab. In fact, we spent 10 days of this one. I told ma'am 10 days too big. Too long a time, and we enjoyed the Mumbai rain. In fact, we got caught in the Mumbai rains also many of those days. But the learning point was the lab has technology to do anti-endothelial antibody. So the thing is, we need to know to interpret. So if you send all the cases for anti-endothelial antibody, we will be seeing stars. But in cases when you're going for a second transplant, and where the pretest probability of all these antibodies are high, I think that is when it's going to be useful. And anti-AT1 antibodies also the lab is able to can do. AT1 and endothelin, definitely they can do. Endothelin, I think they must be the only center in India or one of the very few centers which are able to do. The test is extremely cheap. It's not costly test, extremely cheap. I think madam charges are, I think, 3,000 or 4,000. It's not very costly. And mica typing is possible. I think talking to her, especially if you are like mica typing is possible. So the different labs complement each other. With some the typing is done by one group of labs, and antibody typing is done by the other group. So basically, it is possible. Mica typing, mica antibodies, anti-AT1 antibodies, anti-endothelial antibodies, all this can be done. And I actually have seen some real cases also there, which we had in the workshop we attended. And then there was one case, clear case, where AT1 antibody was positive, and plasmapheresis was done. We know ultimately the treatment is going to be the same, rituximab, plasmapheresis, but we know the targets. At least we know the targets. And in one of those cases where AT1 was positive, high dose ARBs were given, and the case it was successfully done. Successfully, the second transplant was done successfully, managed successfully. So the technology is available for the non-HLA.
Ilangan sir, sorry for the break. Actually, we're running short of time. One last question actually. Are these AT1 anti-endothelians are antigen specific or non-specific? Like HLAs, actually, MICA, they are having they are also doing in Madurai also. They are, if you are asking for a PRA, group PRA, solid phase, you will be checking along with the class 1, class 2, they are giving a titer for MICA also. But what I feel is many times pre-transplant MICA was positive and 2,000 to 3,000 MFI, and still they are not clear about what to do that actually. I did a transplant for 3 to 4 patients, they're doing well. Sir, are there any antigen specificity like are they defined like your HLA class 1, class 2, or straight away you can check for the antibodies, they are relevant or not? Are they relevant?
You're asking for the MICA one or for all
endothelian, AT1 and all?
They are not. So basically, that is what I said. So if you do start doing for everything, for the first transplant and all that, it's going to cause a lot of confusion. So this might take, based on what after the workshop, this might take like each. Don't do it for the first transplant because you should only do for a high risk transplant, especially for a second transplant, where the pretest probability is high, and it is only a guiding thing. It's not specific. Only for the MICA typing is available in India. For endothelian and AT1 anyway we have, but endothelian we don't have. So that's not going to guide you much. The only thing that will help you is we'll know that it is not anti-HLA antibodies. We know what to monitor. Especially for monitoring, it's going to be useful.
Yes. Thank you, Ilangan sir. We are running short of time. We'll go first.
Rajan sir, one small question, sir, to Satish.
Yeah.
Sir, you're going to do a second transplant, sir, Arun sir. So you're going to do the SAB for this patient. At what duration? When will you going to do the SAB, sir? It's going to be now or just before the previous?
Yeah, before working up for the transplant, we'll do SAB. Not right now.
Okay, sir. Okay. Thank you, sir.
Thank you, Satish sir, for the good presentation. And I call upon Dr. Saravanan and Dr. Vandana. I think so. She is going to present the second case.
Yes, sir.
Yeah.
Good evening, sir. Is it visible, sir?
Yeah. Make it as a full screen.
Yes. Am I audible and visible, sir? Screen.
Yeah. Let's go ahead.
Good evening to all. Myself, Dr. Vandana Arvind from Apollo Hospital, Chennai. So today I will be presenting a case that we encountered. It's a case of DIC, post-renal transplant. Can it be ATG induced? This case was like a really scary one. Though we had a very troublesome and stressful period managing the case, finally we ended up with a good outcome. So going on to the case, it's a 35-year-old female patient who's a native of Assam, unmarried, working as a human resource employee. She was admitted in Apollo Hospital for live related renal transplant on 11th of July 2023. So history, patient was apparently normal till 2014 when she was 26 years old. Then she developed generalized weakness, loss of appetite and headache. Then first she taken a consult from a hospital in Kolkata where she was found to be hypertensive and she was started with antihypertensives. Her creat at presentation itself was 7 and so she was asked to meet with a nephrologist. So she consulted a nephrologist in Kolkata where an abdominal ultrasound was done where she was found to have bilateral shrunken kidneys. The kidneys were non-biopsiable. So she was found to have a chronic kidney disease and straight away initiated on twice weekly hemodialysis. And she was counseled to get the renal transplant. So the workup for the renal transplant was initiated and she underwent the first live related renal transplantation in August 2015 in Assam. So this was the first transplant details. The donor was a father. It was an ABO compatible transplant. Both the donor and recipient were B positive. The ID-NAT was done, which was negative. CDC crossmatch was negative. And HLA showed a haplomatch of 5/10. And the immediate pre-transplant investigations were normal. There was no significant events during the intra-op or post-operative period. And here she was not given any other induction immunosuppression, only she received solumedrol, which was 2 grams over 3 consecutive days. Post-transplant period, it was uneventful. She had like a sequential fall in creatinine with good diuresis, and she was discharged on her POD 7 with a creatinine of 1. She was discharged with the following medications, which was mycophenolate 500 mg twice daily, Visolone 20 mg gradually tapered to 5, tacrolimus 2 mg twice daily, along with antihypertensives and other medications. She remained on a regular follow-up and had normal graft function till 2020. In 2020, October, she got the COVID infection and she was hospitalized. During this period, the MMF medication was withheld. But at that time, according to the patient, her graft function was stable and she had good urine output. And following discharge, she was again restarted with the same immunosuppressive regimen. However, 1 month after the COVID-related hospitalization, there was found to be a gradual increase in creatinine up to 2 milligram percentage, following which there was again the rising trend in creatinine. First, there was an allograft biopsy which was done in 2021 January, but we could not get the details of this biopsy. But again, by August, she was having the symptoms of volume overload with the decline in urine output and generalized weakness. So she went to CMC Vellore, where her repeat allograft biopsy was done in September 2021. And at this point of time, the investigations which were done in CMC Vellore showed that her creatinine was 3.22. Urine routine showed a protein of 2+. TAC level was 3.5. Other investigations were within limits. So the transplant kidney Doppler, which was done here, showed a high resistive index of 0.8 with grade 1 renal parenchymal changes, raised echoes. And the biopsy showed a sclerosing IgA glomerulonephritis with global sclerosis. 7 out of 11 glomeruli were sclerosed. And there was also a diffuse tubulointerstitial scarring. Almost 75% IFTA was there, and severe arteriosclerosis. So in view of significant chronicity, the immunosuppressive dose was not increased. So she was counseled for a second transplant. The workup for the second transplant was started in CMC, but during the time itself, patient started to have further decline in urine output, and she was developing features of pulmonary edema, and the secreate was also spiking up. She was initiated on hemodialysis through right subclavian tunnel catheter, and 7 to 8 sessions of HT was done in CMC. Following which, in June 2023, she came to Apollo Hospital for further management, and she was continued with the twice-weekly hemodialysis. So for the second transplant, the donor was mother. Blood group of the donor was O positive, recipient was B positive. But during this checkup, she was detected with hepatitis C. HLA typing was done, which was a haplomatch. And we did a single antigen read in which the class 1 HLA showed 3 antibodies positive with a significant MFI of 1,299, 1,903, but the DSC was negative. And the class 2 HLA on single antigen read was negative. The HCV RNA quantitative was done, which is showing 3,793 copies. And liver imaging was done, which was not showing any features of fibrosis. Gastroenterology consult was obtained and patient was cleared for surgery. The immunosuppression was started from -7th day, that is 7 days prior to the transplant surgery, with the regimen which included tacrolimus 3 mg twice daily, MMF 360 mg twice daily, and prednisolone 10 mg once a day. And she was also started with the direct-acting antivirals, which is sofosbuvir 400 mg and daclitaspir for the hepatitis C. The CDC crossmatch and flow crossmatch both were negative. So she underwent the transplant surgery on 12th of July 2023 with a total ischemia time of 94 minutes. She had a very good OT, the intra-op diuresis of 1,600 ml. She was given injection Solumedrol 1 gram at the time of clamp release. The ATG was given as the induction agent 50 milligram in 50 ml normal saline at 10 ml per hour. The blood volume in the drain was 300 ml when she was shifted to the renal ICU. For the first 3 hours following the transplant, she maintained a good urine output, which was more than 500 ml per hour, and she remained hemodynamically stable, and there was no fresh amount of blood in the drain. But in the night, around 11 p.m., there was a decline in urine output to 125 ml. For 1 hour. And first we thought it could be just a transient decline, and 250 ml of normal saline bolus was given, but there was no improvement in urine output. And patient complained of pain abdomen, and this was followed by a fall in blood pressure to 90/60. She was immediately started with inotropic support. The drain volume subsequently started increasing, and the repeat blood gases showed a significant drop in hemoglobin from 8 to 5.9 to 3.7. Ultrasound was done urgently, which showed there was a large hypoechoic collection, likely hematoma in the left iliac fossa, 12.5 centimeter, which is encroaching the allograft kidney and extending into the pelvis. And also there was a high resistance flow. Patient was immediately shifted back to the OT for re-exploration surgery, and she was transfused with 4 units of PRBC. However, on table, there was an unexpected finding, that is, the blood was not clotting. There was a generalized ooze which was completely filling the surgical bed. So continuously, the patient received multiple blood products in the form of platelets, cryoprecipitate, as well as FFP. She received on the first day, that was during the re-exploration surgery, 5 units of cryoprecipitate, 4 units of platelets, and 4 units of FFP. In spite of this, bleeding was not arrested. So patient was shifted to the multidisciplinary ICU in intubated state for further management. And there was a continuous drain amount of blood 400 to 500 ml per hour. So she was resuscitated with IV fluid, which was maintained at 300 ml per hour. Only one good thing at this point was that the urine output improved, and it maintained continuously more than 300 ml per hour. And her blood pressure slowly started to pick up, and we were able to wean off the inotropic support. The antibiotics we started, and it was escalated to meropenem, teicoplanin, and anidulafungin was also started, because we thought sepsis could be one possibility. As blood pressure at this point was high, NTG infusion was started. However, the blood and urine cultures that were sent came out showing no growth. So this was the first POD day 1 post-exploration, re-exploration surgery investigations, which was again showing there was a drop in hemoglobin consecutively, and also the platelet was also dropping. Creatinine, however, came to 1.9. The PT-INR was deranged, and the fibrinogen was on the lower side. D-dimers were raised. So finally, we made the diagnosis that it is a post-op DIC. So the initial focus was on managing the patient and saving the patient's life. So we transfused her with multiple blood products, because she continued to have a drain output, which was very significant and more than 500 ml per hour. And cumulatively, she received 9 units of PRBC, 10 units of cryoprecipitate, 8 units of RDP, and 15 units of FFP. But still, we could not manage the bleeding, and injection tranexamic acid infusion was started. Protamine sulfate was also given 200 milligram over 30 minutes. And then factor 7 concentrate 5 milligram, that is 75 microgram per kg, stat dose was given. And finally, by 4 p.m. on the POD first day, the drain output finally came to a stop, and patient remained hemodynamically stable, and her urine output was good. On the next day, there was no increase in the abdominal girth, no fresh drain volume. Hemoglobin subsequently started to increase. She was extubated, but as she had a significant positive balance, Lasix infusion was started. But on the whole, her blood parameters showed significant improvement. The TAC levels were sent, which was 12.4. Over the subsequent days, her hemoglobin improved, her platelet counts also improved and stabilized. Her creatinine was declining, and she had a good urine output. This was the repeat transplant kidney study, a Doppler study, which was done before like almost 7 days after this event, which showed that the transplant kidney showed normal echoes and there was no collection. And patient was finally discharged on her 8th POD with the following medication: tacrolimus 3 mg twice daily, MMF 360 mg twice daily, prednisolone 30 mg, and other medication. And also the hepatitis C direct acting antivirals were later added. So this is the happy picture finally. And now the patient is doing well with no complaints and she's having a good graft function. Her last follow-up was on 1st of November and she had a creatinine of 0.9. So this is a case of DIC post-renal transplant. And as far as this case is concerned, the possibilities that we had to see, we were initially up to managing the case. So only retrospectively, we were thinking what could have caused the DIC in this particular patient. So first possibility, we thought of sepsis, but as all her cultures were negative, we had to rule out sepsis. Second was a rejection, but because she had a good graft function and her urine output was almost good all the time, so the rejection part also we ruled out. TMA also ruled out because she did not have any kidney injury, acute kidney injury at that time. Then liver disease related disease, that is also not a possibility in this case, even though she's Hep C positive, because the liver enzymes, even at the time when she went into the DIC, was normal. The last possibility we thought it could be related to any of the drugs. The anesthetic agents which were used in this patient were propofol and sevoflurane, but both these agents, we don't have any literature regarding causing a DIC in a post-op patient. And the final thing which we thought of was an ATG-induced DIC, and we tried to search up literature regarding this when we found out that there is a article in which there is a similar case scenario where a rabbit-derived ATG was used for a second retransplanted patient. And this patient, almost in the same interval as our patient, went into a DIC. And she also had to receive multiple blood products, but only thing was this patient had a very delayed graft function requiring hemodialysis for that period. But ultimately, this patient also had a good outcome. So that is when we thought that the culprit could be ATG, rabbit-induced ATG, rabbit-derived ATG. Then we tried to discern how this ATG could cause a DIC. Then it is like the ATG, which is derived from rabbits, are actually having antigenic differences from the human immunoglobulins. That is especially in the expression of sialic acid residues, which are not there in the human IgGs. So the anti-sialic acid residue antibodies are known to pre-exist in the human beings, and this can elicit a type of immune complex mediated hypersensitivity reaction, like a serum sickness type. And in extreme cases, these immune complexes can also lead to uncontrolled acute activation of inflammation and coagulation, which can result in an acute DIC. This is a small picture showing how the ATG is being produced. ATG, the immunization of the human thymocytes with either the equine, that is the horses or the rabbits, and this results in a xenogenic polyclonal antibody production, which is finally purified with a cytotoxicity assay, and then we'll get the ATG, which we use for the induction agent, which we use as an induction agent. This is a short slide showing that the proper reconstitution of the ATG is also very important. That is the ATG every vial, that is the 50 ml of normal saline or 5% dextrose has to be diluted per vial. And then we have to have a slow infusion over 6 to 8 hours, ideally via a central line or via a wide bore peripheral line. That is all.
Thank you, Dr. Vandana. Dr. Saravanan, your quick wrap of the case actually.
I just add up on this one. Actually, it's a nightmare for a nephrologist and even for the surgeon. So, like, the day what happened, the mistake, like what I found, ATG, was given in a theater in a buzzard way. So, what means we have written a clear orders, like it should be given mixed into 50 ml. NS and should be given over to 6 to 8 hours. But what the anesthetist meant in a different way, he just mixed in 50 ml. In that 50 mg, he mixed in 50 ml and he just gave 10 ml per hour. And after seeing, like, no, I was little bit, like, no, kind of expressed my kind of displeasure to the anesthetist, and I called, like, no, so you should not give in that way, like, no, if it causes hypotension, like, no, if it gets some reaction, like, who will is responsible for that? Because it's the second transplant this patient is coming to us. So luckily, like, no, she didn't have any kind of hypotension, but to that, like, no, till that ATG finishes, by the night, the started, like, no, kind of hypotension. I was initially thought, like, no, it could be because of the ATG that was given wrongly in the theater. So I was confident, like, no, it should settle in an hour or two. But, like, no, suddenly, like, no, her BP dropped to 90-60, even, like, no, the BP crashed, like, no, systolic to 60, and pulse was very feeble, and she was on the drain, like, no, it's continuously oozing, like, blood, it was oozing. And we immediately shifted to a theater, and surgeon opened the, like, no, and I also accompanied the night, like midnight around 2 a.m. So we were in theater, and there was a generalized oozing. We don't know, surgeon couldn't find, like, no, where it was bleeding. So whether it's bleeding from the major arteries or, like, no, he said, like, it's a generalized oozing. We couldn't find anything. And we did a TIG also, like, no, surprisingly, we couldn't find any abnormality. And we sent, like, no, by the time, like, no, we have given many products. We were not sure, like, no, because of these products that she received, like, no, because of that, TIG was normal. So, and I thank, like, no, my kind of my senior colleagues who helped me a lot. Actually, they came also in the morning time. By the time, like, no, I just rang them up, and, like, no, and I said, like, from my side, like, no, I couldn't find the answer. What is the reason for the bleeding? And means we ruled out sepsis. But obviously, she should not have any sepsis. We sent the cultures. We have increased the antibiotic. We even gave a antifungal also, and other possibilities whether she was having any rejection, we don't know. That, like, no, the SAB was class 1 was mild positive, but it is, like, no, kind of 1,000. So I'm very pretty sure, like, no, it should not be a rejection. The only thing that saved me, actually, not that patient also at last, is, like, no, she was having a very reasonable urine output. So she was making good urine output, like, no, at the time, like, no, that if you see the drain per hour, the 300 to 400 ml of blood is, like, no, going out. And she's at the same time, she's having a reasonable 250 to 300 ml of urine. We didn't do a biopsy because it was a bleeding like anything. So we didn't want to do any biopsy and all. So that thing only, like, no, saved me and saved the patient. And her BP, in fact, like, no, initial transient hypotension, BP shooted up. And we even started NTG also along with Lasix also was given. So we exactly, like, no, I don't know what happened actually. And, like, my senior colleagues came in the morning time, like, no, and sat with me, and they were breaking the rates, like, no, in the entire room, like, no, almost like 20-25 doctors were in the ICU room with patients, like, no, myself and vascular surgeon, hematologist, a lot of nephrologists, like, no, they were breaking it. What could be the reason for this? Whether, like, no, and hepatologist came, and, like, no, this is not a DIC because of liver disease, because liver function was done just a week before transplant was normal. And suddenly a patient should not go for so much of decompensation because of HCV. The HCV load also very much pretty low, 3,700 something. So we were breaking, and at last, like, no, kind of, we came to a decision, like, no, to give a Nova 7. So before that, like, you just imagine, she has received almost, like, no, 96 blood products. That's, like, no, kind of, like, no, whatever, like, kind of going out, and we are just replacing. And we thought to save her life. And one of our senior colleagues, like, no, advised me to go for a graft nephrectomy. So this is the reason, like, no, thing. But something in my mind, like, no, sting me, like, no, not to go for a nephrectomy. She's having an urine output. And, like, no, a lot of people, like, no, came around me and, like, no, you're taking this decision, like, no, the graft should come out, then only she will be alive. Don't take the chance, like, no, let her be alive. We will face all the consequences later. You just remove the kidney. But something in my mind, like, no, prevented that one. I said, like, no, she's making urine output. I'm very pretty sure she's not having rejection. Something has caused the problem. So we'll wait. And suddenly my liver colleague, actually, because it's very common in liver transplantation, especially after the diseased liver transplant, they said, like, no, you try with Nova 7. So I said, like, no, okay, it means we have given almost 96 blood products. So we'll try with Nova 7, like, no. But once we got the vial, like, no, the ideal recommended dosage of Nova 7 is 200 mics per kg. So 200 mics means now she will require a minimum 3 vials. You imagine what's the cost of 1 vial, no, Nova 7, it's a 3.5 lakhs, that's all. So like, no, there is no option. First, what is a live or the cost of this thing. So we have promised from some package, we know we are working in a corporate setup, like, no, we should do in some in package. If package exceeds, like, no, the management breaks your head, like, no, why it's expected. So I said, like, no, whatever, like, no, let it be, but whatever the Nova 7, let it come from our package, we'll save the patient. So it's like, no, the 3.5 lakhs, like, kind of 3 vials, like, no, saved her, what I don't know exactly. So we gave her, just like it's not like an infusion, just you have to push like this, that's all. So it's not like no blood you have to give actually. We just gave a small kind of a 5 ml vial, like into 3, like we just pushed her. The moment we pushed, within half an hour to 1 hour, like no, our bleeding stopped. And like no, thank God and thank the liver, like it is a junior consultant, in fact, actually. He just came, like, because it's like no, almost some 25-30 dogs in the room, like no, we're giving each one giving suggestions to the patient.
Dr. Saravanan, very much thank you. Actually, we are running short of time, and many more congratulations for acting bravely and saving the patient. Congratulations to the whole team. And what I could learn from you that DIC could happen without any cause. Actually, probably ATG, we have racked up ATG as a cause of DIC, and also Nova 7, that is factor 7 precipitate, factor 7 concentrate can bring down the level. So, Sheila, madam, your opinion?
No, I have not seen a patient with ATG induced. I have never thought of that possibility. Once in a while, we face post-transplant bleeding issues, but most of the time, we will not reach anywhere in the diagnosis. And giving lot of plasma or blood products, it spontaneously stops. And the factor 7 concentrate, we can't imagine because it is not in our hands of poor patients.
Yes, madam.
So okay, not that
what would you think in terms of cause etiology of DIC in this patient, madam, quickly?
Most of the time, we think in terms of sepsis immediately in the post-transplant. But all the investigation for sepsis will not push you into the diagnosis of DIC usually in day-to-day practice. And we presume that it is sepsis and DIC and step up your antibiotics, give your plasma and other products. And spontaneously, usually it subsides by itself without a definite diagnosis.
Okay.
That is what usually happens.
Here, PTI and APT is not that much elevated, actually. It is around 20.
Elevated, yeah.
It's not that much elevated to produce such a
torrent. 37.
37. Producing a torrential bleed, I cannot explain that.
Yeah.
Thank you, madam. Dr. Ilagan,
yeah,
any experience?
I have some something near to what he had. And so, congrats, Saravanan. I think you have been brave and despite all the distractions, you have been focused and you managed to save the patient. So mine was not like his. We did a double filtration plasmapheresis for an ABO incompatible transplant, and we didn't realize that. So we were like thinking like we don't have to replace much, so we were like replacing less. And later we realized double filtration is very powerful in removing all the coagulation factors. And then we have to give lots and lots of plasma. And we, in fact, got those vials factor 7, activated factor 7 concentrates. But luckily, just before we could, give it, the bleeding stopped. So we were using the crude clotting time we used to do for snake bite in government hospitals. We put the blood in the bottle and keep shaking. And I was doing that till it clotted. And then finally, we saved a few thousand for the patient that day. So that was double filtration. And one more thing we should keep in mind other than ATG is like endotoxins. Sometimes many of these injections and formulations what we have can be contaminated with endotoxins, even made by good companies, good factories. We do have once in a while. But usually what I have noticed whenever there's an endotoxin contamination, the situation is extremely violent. You have a DIC and they develop refractory shock. But then we don't know, like if you have a limited contamination, maybe like you can recreate something like what Dr. Saravanan described. And from the numbers what Saravanan showed, so the low fibrinogen is actually, we tend to miss it. fibrinogen doesn't let a solid clot to form. So even with not so deranged PTA-PTD, you can have delayed bleedings. Usually delayed bleedings are usually a feature of low fibrinogen. And so when in this case, there's no immunological problem. But then even when you solve this current bleeding, a week later, if you do a biopsy, you will have a torrential bleed again because of low fibrinogen. So the endpoint of treatment in all these things should be fibrinogen also. It's not just PTA-PTT, because you tend to have bleeds. Generally, nothing major happens. But if you end up doing a biopsy, say like 1 week later, the fibrinogen level wouldn't have still recovered enough in these situations, and you will definitely have a second bout of severe bleeding also. I think that's something that we need to be mindful.
Thank you, Lemon sir. Actually, good point to take actually. So if you plan for any intervention, you have to look for fibrinogen level. We used to do it at ABO post plasmapheresis, 3 or 4 sessions. We do fibrinogen level prior to transplant to see look for bleeding complications. And any comments, Dr. Satish, your comments on this patient and what could be the possible etiology? We are breaking our heads regarding the etiology.
First of all, I should congratulate Saravanan for brilliant management of this patient, because this sort of case leads to premature graying and early atherosclerosis also, because of all the stress that includes. And the other stress also, you put the patient in the MDICU, so the critical care specialist will be thinking in another direction. So you have to herd them into your type of thinking also. That's also another stress which you have to bear, because you set everything in the morning and go and they'll be doing something else. You have to come back and it's a big stress. If it's not the transplant ICU, the stress is even worse. So this was a terrible case, and fortunately, patient had a good ending. Just one question: was the first transplant, I thought, was Besiliximab, no? Or was it?
First, no, they didn't give any induction. They didn't give any induction actually.
No induction.
Yes. Sir.
Okay. Because then, if there had been a prior exposure, you can say that could be a accelerated hypersensitivity reaction which caused it. That is possible. But I think overall, if you look at it, the picture is more search of DIC. Excessive bleeding is there, no? So that excessive bleeding requires some cause, and that is most likely DIC. And you had features, you had definitely some increase in the prothrombin time and a very low fibrinogen. So both those features suggest you have DIC, and the most likely cause here, because of the absence of sepsis, is your ATG only. I think your diagnosis is spot on. I think we have to consider that only as the most likely possibility in this case. Rare as it is still possible. I think one of the things, like you said, was the fast. I was wondering, because you said 50 milligram and 50 ml. So actually, I was thinking, this is not the way I'm giving it. Am I going to be doing wrong?
One quick question, sir. Does ATG induced DIC? It's an isolated one, or it will produce some other things? Actually, antibody response is there. So it's isolated DIC is some other manifestation like ARDS.
It's a generic thing. No? Whatever produces the DIC, the subsequent events are the same. They have extensive bleeding and clotting. Both of them will be occurring. In this patient, mostly it was a bleeding and consumption of coagulation factors. So therefore, there was a lot of bleeding which was occurring in this patient. So that's what happened. And
what the slides she has put, actually, there is an antibody against this polysaccharide. We have a natural antibody that can bind with that. Does it involve other immune complexes mediated cytokine release and other symptoms of cytokine release will be there, or only isolated DIC?
This one. Actually, ATG can produce cytokine release syndrome also.
Yeah.
So it's very much possible.
Okay.
Just like OKT3 used to in the old days.
OKT3,
So I don't see any other questions from the chat box, actually. Actually, we have. Yes, sir.
Yes, sir. I'm Dr. Anil from Bangalore Global. We had a similar case like Dr. Saravanan. I was wondering it could be some other cause. Actually, it was a 30-year-old male, native kidney disease IgA nephropathy, first transplant. We had given ATG because these days we did not have Simulect actually. So on the after the anastomosis, we saw from the bed there was some oozing. So we didn't know that what is the cause actually, because it was a clean case and he was well dialyzed. And we ended up giving similar like around 40-50 products. So we also had to give Nova 7 in this. Fortunately, we had a good liver transplant program. We had one in our pharmacy. So we had to give one. And after some 50 products and Nova 7, actually, we did not close after the transplant. We waited till almost 7 to 8 hours, actually. Then we had to close it, stop. And subsequently, the next day, he did very well. And he went home on the, say, 5th post-operative day, actually. So we didn't know, actually, because there was no sepsis, cultures were negative. Pre-transplant, he only had a jugular catheter in situ, actually, before. We just thought it could be some occult sepsis. We did not realize that it could be, this could be possible because of ATG. Though we do sometimes see, like what Dr. Saravanan, the anesthetists, they just add in 100 ml of normal saline and try to give it over fastly, without, if you don't monitor them, so we find them suddenly pushing off ATG. It's quite commonly seen by the anesthetist. They do that. But I don't know whether it is the infusion which matters or it is the immunogenic reaction which is caused.
Thank you. One more question. Actually, do you suspect any congenital disorders of coagulation factors that might be causing this problem? But your first transplant is okay, actually.
Yeah. It was okay, so we didn't check, but hematologist advised to do all the coagulation patterns that we sent. The report, like, no, it won't come like in a day, or like, no, it came very late, actually. By the time there was some low normal fact values were there, actually. But they impressed, like, it could be because of the bleeding, like, no, it could be a low level. So it may not be right time to do all this coagulation factor at that time. Because it was bleeding, no, she was bleeding. So it could be low.
Okay.
We sent that all the coagulation factors. But even like, no, I just answered Dr. Ilokuman's question, like, no, I was advised to do a second biopsy. I mean, not second biopsy. I advised to do a biopsy when she was stable, when she was about to discharge, but I didn't touch her. I said, like,
luckily.
Problem, like,
okay.
Because then what is the point in doing a biopsy at that time? Like, no, I said, no biopsy. Let her go home happily. Another thing, like, just for Satish Balan sir, like, no, the MDCC people, like, no, they drama create, like, no, the next day morning, like, no, the one consultant, he's a friend of me, he just came inside the room. I was like a Leo Vijay, my ass says no, because of, like, no, I didn't sleep the overall night, like a Leo Vijay, my ass was there. He thought like I'm a bystander of the patient. He said, like, no, you go out. Sir, I'm the primary doctor. Like, no, I should be. You go outside and manage now. So it happened, like, no, the MDCC people always think in a lateral way, like, no, I'm saying, like, I'm a primary doctor. He said, you first go outside, you will manage.
Yeah. Dr. Gauri Shankar actually has raised hand. Any doubts? Just clarify.
Yes, sir. This is regarding the coagulation factor defects. The coagulation factor defects can present at any point of time. Need not be that the first transplant has happened in a positive way so that a coagulation factor defect is ruled out, because there has been proven tissue pathway defects and congenital factor 7 deficiencies which can happen at any point of time. I myself have had patient of IgA nephropathy, crescentic IgA nephropathy, who was actually done ABG for analysis of his blood gases, and he started bleeding from the brachial artery torrentially. Later, when we worked him up, he was found out. We found him to have congenital factor 7 deficiencies. And while going through the literature, his mother was also affected. While going through the literature, it was seen that with IgA nephropathies, you have more mucosal defects associated with it and coagulation factor deficiencies. As you can note, both these cases had IgA. The one which has been told by a consultant from Bangalore, and the case of Dr. Saravanan had a biopsy-proven IgA nephropathy. So that is one association which has to be taken into consideration. And you can also see that the temporal correlation between Novo 7 administration and the improvement in symptoms, I am not very sure. Retrospectively, we can take that as one of the plus points. But then we have to prospectively evaluate these patients, as if the patient has been off all these coagulation, any drugs which is causing coagulation defects, or any other blood products which has been given. So we can get a factor 7 done in these patients. I would like to know more about the pre-transplant the coagulation profile. If there is even a slightest elevation in PT, that may point towards a congenital factor 7 deficiency. So that has to be taken into consideration. So when you bleed, obviously it will lead to a DIC picture because the coagulation pathway is in defect. So you will obviously have a DIC. So there is no point in proving it, prospectively. So that's my say. Thank you.
Gauri, actually, one question is, APTD is also prolonged. Actually, do you still rack up the platelets are reduced? And is an isolated factor 7 deficiency can produce such kind of picture?
Sir, that it is post-bleed. So post-bleed, any kind of DIC can occur. And once a coagulation pathway defect has started bleeding, so it is going to be a snowball effect. So it will lead to a DIC picture. After having a DIC picture, you will have thrombocytopenia and all those things. So that is why I'm much more interested in getting his pre-transplant coagulation workup, which is that matters a lot.
It was Dr. Saran, do you have any? It was normal.
Normal actually for PTA.
No, I have a completely different take on what Gauri said. So usually, in adult cases, factor 7 deficiency come with clotting paradoxically. In fact, I managed a case like that, and I did a reasonable literature survey that time. I think we published it also in Indian Journal of Nephrology. So in children, in newborns, they come with the intracerebral hemorrhage, and if they don't die in the newborn period, they tend to have an alternate mechanism where they have clotting tendencies. In fact, in our case, we did diagnose factor 7 deficiency. It was undetectable factor 7, and then we actually gave him anticoagulation in the post-op period. And he had a catheter. He had a catheter-associated jugular vein partial thrombosis. So factor 7 deficiency paradoxically comes with this one clotting, and if you accidentally try to transfuse, they tend to have more DVTs and clotting. So that's this one. But they do have clotting, bleeding problem, but that's generally a problem in young children and newborns especially. And as like what Rajan sir described, here you have all the things involved, platelets and PT, APTT, and I don't think it fits into a coagulation factor deficiency. It fits more into a DAC.
So both the points are well taken actually, and I could see any other comments from the audience.
Have gone actually. So this patient, we were discussing whether we can add an endotoxin filter actually, because Dr. Ilangovan sir has pointed out, whether endotoxin has precipitated without any cultures was negative and whether it's triggered a DIC, whether we can use a cytosorb. That was a discussion was happening actually. But by the time, we just gave Nova 7, she has improved, we didn't proceed with that one. So that is also in our discussion mind was going on actually. So just use the cytosorb and just...
So a quick question actually. PCC prothrombin complex concentrate, any experience regarding this instead of factor 7? That would be working out cheaper.
Yeah, that also thing. But the thing is the inhibitory capacity of the PCC complex, we just that time we were reading actually. So it's so and so maybe some hematologist can, if you are there, they can answer. So means you have to give so much of PCC to inhibit that kind of bleeding. For that, the simple Nova 7 one bottle would be equal enough.
Right.
It's kind of the bleeding, bleeding arrest equation between the 1 vial of PCC and 1 vial of Nova 7 is not equal actually.
Fine. Thank you.
The coagulation effect, the correct word.
Thank you very much, both the speakers, and we have actually exceeded our time actually. So it was a wonderful learning experience. First, with the hyperacute rejection, could be a HLA or ABO incompatible, but the points are well taken about the B cells and types of B cells and which producers, and it was a wonderful basic information given by Dr. Satish sir. And titers won't matter actually. Any titers can produce hyperacute rejection in ABO incompatible transplant. That's what we have listened. And legal issues, we have to take care of the legal issues, what we have understood from this presentation. And regarding the second presentation, and still we are eluding the cause of DIC, and probably we have in consensus that would be due to ATG induced. So we'll be having, you should have in mind that DIC can occur with the ATG infusion also. and very good presentation. And thing is, not over panicking and going for nephrectomy, and just he waited and gave around 90 units of blood products and brought out the patient out, and that was a great and valiant attempt. And thank you. And one issue was regarding the congenital factor 7 deficiency. There was two varied thoughts process, one with the bleeding and another one with clotting, favoring clotting with factor 7 deficiency, and needs a lot of workup, and we'll come up with some answers. So thank you for having the wonderful presentation. I must thank the panelists for coming here and sharing their thoughts. And many congrats to the speakers for managing the patient, and also brought us your experience and taking a lot of time in preparing the slides. And once again, we allow to thank our audience who were always active and made us this group a wonderful group. And I must thank the MQ team for AV support and all. And it was a happy learning experience. And with the Diwali around, we wish you all a happy and prosperous Diwali. We'll meet next month, actually, for the first Saturday. Thank you very much for joining us, sir. Thank you.
Thank you,
have
Doctor.
A good sleep and happy Diwali.
Diwali to all.
Thank you very much.
Thank you. Happy Diwali.
Yeah.
Have a good and happy sleep. Thank you, sir. Thank you.
Thank you all.
Thank you, sir. Happy Diwali, sir. Good night, sir.